Hello and welcome to clinicalpath.com. This lecture is on pulmonary vascular disease. We're going to discuss two topics in this. We're going to be talking about pulmonary hypertension and we're going to be talking about pulmonary embolism. So let's start with pulmonary hypertension. First of all, let's get the terms right. There's a wrinkle in the term pulmonary hypertension because the strict definition of pulmonary hypertension is basically any disease in which pulmonary artery pressure is going to be greater than 25 millimeters of mercury. But you've got to distinguish between that definition of pulmonary hypertension from the term pulmonary artery hypertension. Because pulmonary artery hypertension is the new term for what we used to call primary pulmonary hypertension. So in other words, pulmonary artery hypertension is a subset of pulmonary hypertension. So when we come to the classification of pulmonary hypertension, this is the WHO modified criteria. It starts with pulmonary artery hypertension. So pulmonary artery hypertension, a subset of pulmonary hypertension, is divided by the WHO into idiopathic, so that makes sense, no one knows what causes it, versus familial. So this is going to be our group with the bone modeling protein receptor 2 and all the other known genetic problems. And then a group that they call associated. So the associated group is going to have the same arterial proliferation problem, which is going to include a number of things, but specifically for us, the connective tissue disorders like scleroderma, lupus, that family, and Eisenmenger syndrome, which we see when we have a large enough left to right shunt. Then we go into what they call the secondary causes. So the second category, and this is how WHO numbers them, is going to be pulmonary hypertension associated with left heart failure. Group 3 is pulmonary hypertension with pulmonary hypoxia. So these are mostly going to be our lung diseases, COPD, and our interstitial lung diseases. Group 4 is going to be pulmonary hypertension with recurrent thromboembolic disease. And then the last group is going to be miscellaneous. So we can see then we've got to be able to handle our primary group and then left ventricle failure, pulmonary hypoxic change, most commonly is going to be COPD in our culture with cor pulmonale, and then thromboembolic disease. So let's take a look and make sure we can do the pathophysiology for each of these. Remember that when we talk about pulmonary artery hypertension, formerly called primary pulmonary hypertension, this is when we have a decrease in our vascular luminal cross-sectional area. And this is mostly going to be due to diseases of the small pulmonary vessels. Because the small vessels, just like anywhere else, those are going to be our resistant vessels. And so this resistance in the pulmonary arteries is going to be due to two things. It's going to be due to endothelial defects and smooth muscle proliferation that are going to lead to remodeling, and then perhaps as well, not totally clear on this, some component of vasoconstriction. So when we talk about pulmonary artery hypertension, we're basically talking about remodeling of the small arteries, giving us a decrease in their cross-sectional area. When we talk about cor pulmonale, right, this is going to be the response of the vasoconstriction, which is a poorly understood but well-described phenomenon that keeps VQ matching in lung disease and any other condition of hypoxia. Recurrent pulmonary embolism, this is going to decrease our cross-sectional area just by occlusion, but this is mostly going to be a disease of our hypercoagulable patients. And then congestive heart failure, that pathophysiologic mechanism is basically going to be due to increased pulmonary vein pressure following left-sided pressure. So those are the three basic pathophysiologies. The primary is going to be remodeling of small vessels, cor pulmonale, vasoconstriction to hypoxia, recurrent pulmonary embolism, loss of cross-sectional area due to occlusion, and then left-sided failure from the pulmonary vein pressure. The problem with pulmonary hypertension is the symptoms are very nonspecific. So we're really talking about the surprisingly difficult findings of shortness of breath, fatigue, and right-sided heart failure if we're approaching the end-stage disease. On examination, very difficult to make a diagnosis. The high pulmonary pressure can lead to an increase in the pulmonary component of S2, and if it goes on long enough, you might get right ventricular hypertrophy, so that's going to give you a left parasternal heave. Those are not straightforward physical exam findings. So with our finding of anything to do that suggests this, we're going to have to go to specific testing. So let's take a look at what we'd expect based on the pathology. If we had a chest x-ray, we would expect to see a right ventricular hypertrophy. So what that's going to look like, let's just sketch out a chest x-ray here. There's our normal. What we're going to see is we're going to see that prominent right heart margin. If we were going to do an EKG, we would see right ventricular hypertrophy and right heart strain. Basically, everything is going to hang on your Doppler echo. Anything to suggest this, echo is going to be your go-to test. And what that's going to show is it's going to show dilation of the right atrium and ventricle. It's going to show right ventricular hypertrophy. And it's going to show an increase in our right ventricular pressure, usually defined as greater than 40 millimeters, because that gets you well above the 25 range of the pulmonary artery. But the gold standard is going to be right heart catheterization. And then with your right heart catheter, you can show that the pulmonary artery pressure is greater than 25 millimeters mercury, which is our definition. Well, the natural history is surprisingly grim. If we're talking about pulmonary artery hypertension, formerly the primary type, most of these patients live less than 3 years. The treatment basically centers around trying to relax smooth muscles, and so CCBs tend to be the go-to drugs. There are many new drugs that manipulate the endothelial cell and smooth muscle proliferation, but at this point they're still in testing. So if your CCB fails, your ultimate result is you have to go to a lung transplant to replace the damaged organ. Well, let's move on to pulmonary embolism. Pulmonary embolism, you'll note, it is not a disease, but it is really a consequence of deep vein thrombosis. So the disease is hypercoagulability leading to deep vein thrombosis. The complication of that is pulmonary embolus. So when we talk about venous thrombosis, we're really talking about Virchow's triangle. So this is Virchow's triangle of hypercoagulability, which relates to the endothelial cell, which has some sort of injury, because that's a critical cell in coagulation. Anytime you have abnormal blood flow, and then the last is a situation where you have increased coagulation of the patient. So that's our causes of thrombosis, but the actual consequence depends upon the size of the vein. So we can have a very large vein, which could be pelvic or femoral, and these are going to lead to the symptomatic pulmonary embolism, which is going to be our shortness of breath and hypoxia. But remember, many of these can be asymptomatic, so you have to anticipate the risk of your patient in this setting. The next size we want to think about is going to be the medium-sized veins of the calf. So while calf venous thrombosis may be painful, it has a much lower risk of significant pulmonary embolism. The one wrinkle here is that it's actually small enough to go through a patent foramen ovale, and that of course can lead to a stroke through a paradoxical embolus. And then the last are the superficial veins that we think of with our varicose veins, and these are not typically thought as being big enough to cause symptomatic pulmonary embolism. They do cause varicose ulcers, but what they really are is they're a marker of risk for pulmonary embolism. Because if you're thrombosing those little veins, you're thrombosing everybody else. So about 1% of these patients will have a pulmonary embolism over the following 3 months. So any venous thrombosis carries a risk. When we talk about in medical school the standard one, we're really talking about the large ones that are going to compromise pulmonary vascular flow. When we talk about pulmonary embolism, remember that most are going to be asymptomatic. So it's a disease that you really have to keep in the front of your mind, because this is the commonest reversible cause of hospital death. So this is called a high degree of clinical suspicion. You're going to suspect it anytime you have a patient that is hypercoagulable. And we're going to be talking about that when we talk about coagulation diseases. Then you're going to think about it in anybody that has respiratory symptoms. And of all the findings that we get, so that's going to be things like chest pain, shortness of breath, development of hypoxia, because you're following their oximeter, the single most useful physical finding is going to be an increase in the respiratory rate. The classic description of pain, shortness of breath, and hypoxia as the classic medical student presentation, that's less than 10% of your pulmonary emboli. So, when a patient presents with the classic symptoms, which are going to be shortness of breath, in your mind you're going to think of this pathophysiology into two groups. Early on, immediately after the pulmonary embolus, this is going to be dead space because you've got aeration without perfusion. But after hours, we start getting vasoconstriction and bronchoconstriction, and so late there's going to be VQ mismatching as the cause of the shortness of breath. Physical exam is mostly going to be negative. If you have a patient with underlying chronic obstructive pulmonary disease, you might have pleuritic chest pain, but unless you have something to compromise the normal vasculature of the lung, really you're not going to see ischemic effects. Most of the time in this setting, all you're going to see is an increase in the respiratory rate, certainly greater than 16 per minute. So what are you going to do in testing? The key to testing is to understand what is the level of risk. What is the likelihood this patient has a pulmonary embolism? And you're going to look at two different levels. You're going to look at patients that have a low risk, because these are patients in which all you're going to do is a D-dimer test. If they have a high level of risk, then you're going to do a CT angiogram. So you're going to suggest high risk when there's an increase in the heart rate, when they're old, age greater than 65 is old, if they have any positive history of DVTs or prior pulmonary embolism, or if they've got any history that makes them hypercoagulable, and that's going to be most of your hospital patients who are bedridden, overweight, post-surgical. Those are 3 risk factors in and of themselves. So anyone with these high risk factors is going to go to CT angio. So let's just stop for a second and say, what do we mean by the D-dimer test? Well, this is how it works. Up here, this is an example of our fibrinogen. So fibrinogen is a long fiber that starts with fibrinoproteins attached. And when it is activated by thrombin, factor 2, the fibrinopeptides come off, and that allows it to spontaneously organize. Now look at how it's labeled. The central portion, this domain here, is called the E domain. And the two outside portions are called the D domains. And when these fibrinopeptides are released by the action of thrombin, you can see then that all of these fibers, as we see here, can aggregate. But you notice there's no covalent bonds. This is all electrostatic. Factor 2 also activates factor 13. And it's factor 13 that creates all of the covalent bonds between the D domains. The act of forming fibrin and cross-linking it also activates fibrinolysis. So this is now fibrinolysis through the activation of plasmin. And plasmin is going to chop up the clot in lots of different ways. And the smallest fragment that it clips off is this fragment here, which, as you can see, is the joining of two D domains into a two-piece bit. So these two pieces then are a D-dimer. So D-dimer then is a hallmark of fibrinolysis, a marker in itself of thrombotic disease. If the D-dimer is negative, then your patient has no evidence of fibrinolysis and therefore does not have significant coagulation going on, and that therefore rules out pulmonary embolism. When you do your angiogram, you can actually see the clot, so you're going to use this for your high-risk patients to rule in pulmonary embolism. So we can see in this CT image a CT angiogram in which we can see here's the aorta here, and here is our descending aorta here. So this is our pulmonary artery here. And in this we can see what must be an old clot because it's hypodense. And we can see it here extending into the left pulmonary artery and here extending into the right. So it's straddling the branch, so therefore this is a saddle embolus. So what do you do once you've diagnosed a pulmonary embolus? Well, the treatment depends on whether it is a high risk or a low risk clot. So if we talk about a stable patient, and stable means that there is a normal blood pressure. Some groups will also include no evidence of right ventricular decompensation. If they're stable, then you're not going to do anything about the clot itself. All you're going to do is anticoagulate them to prevent more thromboembolic events. But if the patient is unstable, meaning they've got hemodynamic compromise, there is a decrease in blood pressure, or as we've discussed, some groups say right ventricular dysfunction, these are patients where you have to go do an embolectomy. So you can do that mechanically by going in and fishing it out, or you can use a clot buster and put them on TPA. So pulmonary vascular disease is two major entities. It is pulmonary hypertension, and remember that's different than pulmonary artery hypertension, which is primary. And then there's pulmonary embolism, which is not itself a diagnosis, but rather a complication of deep vein thrombosis. So the key to pulmonary embolism is a high degree of suspicion, and then approach to your patient is low risk, rule out with D-dimer, high risk, CT angiogram. And if you find a pulmonary embolism, is your patient hemodynamically stable, then just anticoagulate, or is your patient hemodynamically unstable, you have to remove the embolus. That brings us to the end of this tape. Thanks for listening.